The topic is important. Laser surgery, innovation or incremental improvement? We have to ask ourselves. If you own a laser tomorrow, for those who don't have it, in which patients would you use it and which patients you will not use it? You need to be very clear before you leave the hall today. Now, Gartner hype cycle in laser proctology. What does this mean? Any new instrument which comes in the market, everybody jumps to it. Okay, I'll be the first. Let's buy it and let's do it. And initially, the company really sells. You see this graph going up. They sell a lot, and everybody's got a laser machine. Now they're supposed to come up with good results, and they have bad results. And gradually they start telling, don't buy, it's bad, don't buy. This is for all the instruments which are in the market. And it goes down with the disappointments and failures. And that's what was happening, especially in recurrences in fistula, for which the machine people were buying, especially for problems in hemorrhoids, for which people were buying machines. Then some people, some innovators, start looking at these disappointments and start to change it for the better. And when you start following this, you see the graph goes back up. The slope of enlightenment and plateau of productivity, I think we are here between these 2 points, slope of enlightenment and plateau of productivity. So team ACRSI is working hard. We're doing laser workshops at least twice a month. We're going to have a lab course whenever we have a conference, trying to address. My motto was to address 20,000 surgeons in India in this current year, and we're going towards it very fast. So this can only happen if the team is there. And the team, I'm not telling you to sit here because then they can't see the slides. Now, a typical conference take back whenever they have a laser because the laser company is sponsoring it. Okay? This changes everything. So I'll go back and buy one. Conventional surgery is obsolete. Laser is the thing. There is no pain. That's not true. There's no recurrence. That's not true. It has perfect continence. Yes. But if you use too much energy, no. Industry marketing is the strongest here. Now, if industry was not marketing it, surgeons would not buy it, the patients would not ask for it. You understand? There are some procedures in which the industry does not market, and they are top of the line. One is Dr. Chuti's procedure, which we in India are adopting, and Dr. Kamal has mentioned it. The reason why nobody is marketing it is because only 2 vital sutures are required to do a hemorrhoid surgery, no matter how bad it is. Who's going to market that? And the proctoscope, which is selling, it sells for about 10,000 rupees, and you can use it as long as somebody steals it. I mean, you have it, it's there. It is not, it's unbreakable. So who's going to sell? Who's going to market? Therefore, no takers. So laser, why? So laser provides all these things, but there's a question mark. Would any other panelists want to say anything upon it? Better healing? Yes or no? Yes, if you're in the right time. Less pain? Yes. Lower recurrence? Not sure, because it depends on the surgery you're doing. Better continence? True, unless you give too much energy. Better cosmesis? Yes, the audience can also take part. Faster recovery?
Yes.
So if, I'll give you, and better economics, well, not exactly, the fibers cost a lot of money, but in India we used to reusing it. Now there is something I want to tell, I'm not sure if I should. Biolitic has different fibers for India. And the fibers they give you for 125,000 fiber by is 10 fibers. The initial 20 centimeters, they give you 5 of it. Nowadays, yesterday they told me they give 10. So you can use it twice each. So 20
Ya
times,
udah urus
20
yang
times
terbaik
you can
aja
use
deh
it for
gimana.
the cost of 1 fiber.
Terserah juga
But
saya.
it's only available in India. So I don't know about Bangladesh, I don't know about Indonesia, you have to find out. If that is true, it will take away all the laser machines from the market because the machine is good. What should define value? Hemorrhoids? Kamal, would you like to say anything about it? Right? Grade 2 and grade 3. If you're really smart, you've done a lot, then maybe grade 4 like Kamal showed. Fishers, value added, moderate. Niranjan, you would like to add anything?
Fisher, I am doing only close finger recovery. For fissure, I am doing only closed sphincterotomy. I am very happy with it. Gives good result with a very minimally invasive way. And only the hypertrophic papilla and the sentinel hemorrhoid I excise with laser, because that definitely has an advantage over diathermy excision.
Okay. I'm doing it. Yes, Neeraj?
Yeah, I think I was also very much averse to do fissure with sphincterotomy with laser. I felt the same thing, that the tip of the knife is equally good. But once I started doing it, because patients started demanding it, I realized definitely the pain scores are much lesser, the healings are much faster with laser. Yes, I have not published my work so far because the volume has to justify, it should be more in particular cases where I can justify that. But I would tell you, yes, it is definitely advantageous compared to even blade sphincterotomy.
Yeah, I would agree to it. Now, if you have the option of open and closed, while open, everybody is verified because they see the sphincter. But if you compare both, closed is definitely much better than open. The abscesses I have had of fissure than elsewhere were of all of open. Fistula. Now, fistula is very selective. Arshad, would you like to say where you would use laser in fistula?
See, laser can be used in two ways in fistula. One is for very long tracts which are going away from, laterally or posteriorly. And those tracts you can ablate after just taking care of the symptom disease or the intersphinctic disease. It can help you. So you use the radial fiber for ablating the tract from within and then debriding it, curating it. Secondly, sometimes we are doing intersphinctic dissection. There's a tract which is a high intersphincteric extension, and during that dissection, sometimes we find that the bare fiber of laser can be very useful when you don't want a lateral spread of energy for dissecting. However, you can use it with cautery also, but we can use bare fiber of laser for dissecting the tract or for coring down the tract from the intersphincteric space.
Okay.
Can I add to that?
Yeah.
Can I add to that? So what Arshad said, probably I am doing the same thing, using laser only at tracts which are inaccessible or beyond, which should not be cut. Otherwise, we, like Parvez, remove the entire disease. But there is a caveat here. People, like for example, Parvez, he only curates out those tracts. He doesn't ablate them with laser. But his results are equally good. So we are not sure whether laser is actually helping them, or it is just an additional thing in our hand which we are using.
So we need to put a paper.
So scientific evidence is still lacking on that. Yes, laser can be used with hybrid along with lift or something like that, which is truly minimal invasive. But otherwise, when the supralevator tract or the extralevator tract, whatever extra we update, is just for our satisfaction, I think, because people who don't do it also heals, right?
Yeah. Okay. Final sinus.
I
You
think-
said every. नहीं बोलो Nitish.
I agree with the statement that this is one of the best indications. And if you look at the age of the patient, I think this should be offered as the first choice to
First line of treatment. Correct. Okay, now Dr. Kamal, I invite you to my hospital for Valor's. You said, no, if anybody can teach me, I can teach you how to modify it, because I'm surprised you do it really well. There's something going wrong, where 88.7% is really much more.
I have one question for pylonidal laser.
Yeah.
I have been asking this to you every time you speak about pylonidal
Okay, yes,
laser.
sir.
Yeah. Again, I'll ask you. The basic concept about treatment of any pylonidal disease is of midline closure and flattening the natal cleft, which does not happen in the laser treatment when you do
Correct.
it. And in spite of that, if the results are around more than 90%, as most of you say, how does that happen? Means why then is that whatever we were taught in previous days that it should be flattened or the closure?
Let's go with my experience. Patients who have been operated 2, 3, 4, 5 times, I measure the natal cleft and all of them. It's 1 centimeter. Patients who have been operated only once can be 3 or 3.5 centimeters. I used to think, I never used to tell the patient my results because they were very high and people wouldn't believe me. I don't think flattening the natal cleft is necessary. And that's why we are still hanging on to something which was old and holding it. If it was so, then why is it that 50% of the patients I operate are post flaps and I have a follow-up period of 10 years and they're still okay? Why should that happen? So maybe that foundation, that flattening of natal cleft was maybe not right. And we are presuming it's right. Maybe it's time to change it. And Kamal, I'm really saying, we started together, you should have more than 95%. One of the things I can tell you in the audience, which maybe we are making a mistake.
Sir, my series includes 6 patients which we lost in follow-up.
Okay, just listen to me. One of the things I would say when you're doing lasers,
Ini bang,
we tend
cuman yang harus
to
kita
burn the
perbaiki dari
skin
orang kita
margin.
bang.
Now when
Kita
we
harus
are
bicara
doing
data.
refining, we are
Jadi
taking
kita
out
harus
the
punya
bad
penelitian
margin.
bang.
If
Kalau
you
nggak kita
don't
nggak
burn the
bisa
skin
ngomong
margin,
kemana-mana
you
bang.
don't need to burn
Otak
it.
dalam tempurung
It's
aja.
out of habit that we're burning the skin margin as we're coming out with laser. That will delay healing to 2 months. If you don't burn it, it will heal in 10 days. And this I found out by accident because in 2 patients I forgot to burn it. And we looked back into the films and we saw that we forgot to burn it. We are creating a secondary burn, so therefore that's problem. Second is, if you're not thorough in taking out the hairs, that's why I use a scope always to make sure. Sometimes what I do is I curate everything. So when I put the scope in, there should be no hair. But suddenly you see a hair, or a pocket which has a lot of hair. So yes, you want to say something?
Can I say something? I was doing a lot of flat for piloting sinus many years back, shifted to
Yes,
MI.
I know.
Very happy with that. Only thing is that we close the wound not vertically but horizontally. After doing the gips, I close the wound horizontally so that there is no, whenever there is a lateral traction or lateral shearing force, it will still bring the 2 ends close to each other rather than dividing or shearing of the wound. That's one thing. Secondly, my success rate has been about 75 to 80%, which goes well with the international literature. I don't have a success rate of 90% or 95%. Because the problem comes with long-term recurrence. In MIS, we don't tackle the natal cleft. We don't tackle the deep natal cleft. That's a reason that is related to the long-term recurrence, not to the short-term recurrence. In short-term recurrence, most of the wound do heal in about 15 days time or 3 weeks time. But the long-term recurrence of pilonidal sinus is definitely related to the depth of natal cleft.
Long-term recurrence is labeled as 20 years.
Pardon?
20 years.
10 years and 20 years.
10 and 20
10
years.
and 20 years. So,
And because
yeah.
this is a new procedure, that's why I say I have a follow-up of 10 years.
Correct.
With big labels.
Yeah.
Yes, I agree. Closure, Sanjay closes, you close it, I don't close it. I just leave it open.
And lateral wound should be kept open. Don't close
I
the
keep
lateral.
all the wounds open.
Yeah.
Sanjay.
One thing is that always use endoscope. Never do blind laser ablation. We have come to why it is important, and that is the same echo with the international people who are also doing it. And second, when you use an endoscope, if you have 2 ways, means one caudal end and one cephalic end, always put the scope from both ends because it is limited vision. If you put the scope from one end, you may miss some here at the lateral side.
You get a different view from the other end.
Yes, so that is very important. And these are the important things I just wanted to share, and it's really one of the best indications and very high quality.
Abscess, we don't do laser hemoplasty. Kamal has already told everything. Fissure has been discussed, so we're not going to do it. Fistula, does laser eliminate infection? No. Does it close the internal opening? No. Laser works best when infection is controlled, internal opening is treated, and tract is suitable. Laser fails in all these conditions, we already talked about it. Pineal sinus, we have done everything about it. Where should laser not be used? Advanced prolapsing hemorrhoids, acute sepsis, complex branching fistulas without source control, active Crohn's infection, malignancy, where cheaper surgeries give equal outcomes. The future, this Pradeep has covered, but if he wants to add anything, Pradeep, you want to add anything to any of these points? Yeah, we have to work on this future.
Newer machines, 1700 and 1900 machines are being tested.
I know, they're tested, but I truly feel they're not going to be useful as they're saying. It's another marketing gimmick for you to change over to a new machine.
No, they have been, yeah, they
I
have.
know, lateral burn is less.
Yeah.
Niranjan.
I feel that the procedures were not defined in the textbook. They are all new things, right? So they were not standardized. And that is why there are varying results and varying kind of complications which are happening. The need of the hour is standardization of the procedure, and then see how they go forward. Like we are forming the Delphi consensus on FGR plus laser. It needs to be done probably with every procedures done by laser.
Yes.
Standardization of technique, the amount of energy to be used, the amount of burn which we can cause, and post-operative care, all needs to be standardized. Selection of cases should be a absolute must. Okay, beyond this case, nobody should do laser,
Yes.
and that is where the exact result should come out.
So where does laser truly add value? So the thing is, will you do in all of these? We already discussed, we won't do it. Message is not a new principle, it's a new method of delivering established surgical principle, and you should know the surgical principle. Great value is achieved when applied in the right disease, right patient, and right stage.
By the right surgeon.
No, that is the right surgeon. Don't ask where you can use a laser. Ask where the laser is meaningfully improves the outcome. Just because the patient says use laser, that's not the indication to it. So pearls, I want you to add, all of you, audience also. Laser is an energy source, not an operation. Remember that. People think buying laser will make their lives easier to do it. Diagnosis determines the success more than the technology. The best laser cannot compensate for a wrong indication, as Niranjan just pointed out. Respect anatomy more than the laser, and we don't respect, and that's where we land up with a lot of problems. The laser never replaces knowledge of endoretinal anatomy. We should be very clear about it. Treat the disease, not the laser protocol. Every patient deserves an individualized operation, so you may have to cut down, not deliver more. Go towards less energy than more energy. Always eliminate sepsis before expecting healing. If sepsis is there and you're doing lasers, it's not really going to help you. Abscesses have to be drained and followed up, and then use laser. In a fistula, the enemy is the central disease, not the external tract. Yet we are focusing on the external tract. Failure comes from persistent internal opening and intersphincteric practice. Laser cannot compensate for missed internal opening. Nothing can. If you miss an internal opening, the recurrence is 20 times higher. There's no two doubts about it. Hemorrhoids are vascular, not an energy problem. So, Kamal, you want to add anything to it? Nothing. Lose laser hermatoplasty and do it with FGR. It will really improve results. Do not chase perfection. A small residual skin tag is probable to anal stenosis. Cutting too much is going to cause a lot of problem. Minimum tissue produces maximum patient satisfaction. Tissue injury. So less pain often matters more to a patient than perfect anatomy. You try to do too much, and the patient lands up with a lot of problems, a lot of burns, and that's going to be a havoc for the patient. Correct amount of energy is enough. Remember this. For hemorrhoids, where 150 to 200 joules per hemorrhoid is the maximum energy you can give. For fissure, where 100 watts is the maximum energy you can give. You give more than this, you're going to have mucosal burn or muscular burns. Laser fiber should move. Now, sometimes people are doing a long fissure tract or a pyramidal sinus, and they're talking to their colleagues, and somewhere between them pulling, they stop at a place and they keep delivering the energy. What's going to happen? They're going to make a big hole there. A big cavity. You've created that cavity. Be on the laser, and the fiber has to move. Initially 1 millimeter per second seems difficult, but after time you understand how it is, and if you do it too fast, it's not going to burn. Always see where your fiber is. You are in the wrong plane, you're going to cause a lot of havoc, especially for fissure and hemorrhoids, where it's very important to know you're in the right plane. Protect the sphincter at all cost. Continence is remembered longer than recurrence. So remember, this is true for any fistula surgery you're doing. Error towards the side of recurrence. And if you take out the central disease, even that's going to go less. Laser is the best combined with sound surgical principles. So drainage, curettage, flap, lift, warp may complement laser, which we have talked about, Sharshad talked about, I've talked about. Good post-op care is part of the operation. Now this, please don't take it lightly, it's a really important part, because that you can postpone something. Premature closure you can postpone. Any abscess cavity formation you can do. Hyperpigmentation tissue you can take care of. You don't do that yourself, the patient is not going to get well. Not every patient needs laser. So when the patient comes and says, please do be my laser, I said, I have the laser machine. The choice is mine, not yours. I'll decide in the OT whether I use it or not. The learning curve matters. There's not really a very big learning curve. If you have learned it from a master, and if you've done the procedure on animal labs, then you're going to be okay from day one. Measure outcomes honestly, we don't. We lie to ourselves. We say we have great results, but we don't actually look into what are the things which have go into make good results. Don't look at the marketing claims, look at your results. And if you need help, please ask a person who knows more than you. Remember, our laser does not replace surgical judgment, it magnifies it. So the golden rules of laser proctology: right patient, right diagnosis, right indication, right energy, right technique, right expectation. Patients have too much expectation. Sadly, I do about 10 fistula surgeries in which 5 lakh have been done a month. They had very high expectations of laser, and the first thing they come and say is, whatever you do, don't use laser. Had they said the same thing to the first surgeon, that issue would not have cropped up. And the follow-up is really important. Final take-home message: the future of laser pathology does not belong to surgeons who own a laser. So those who have laser, it's not yours. It belongs to a surgeon who understands when, why, and how to use it. Thank you. Dr. Kamal. Yeah. How much time do we have? 5 minutes? I'm going to take 5 minutes. 5 minutes. Just 5 minutes. Come. Hurry up. So we just wanted to talk about Delphi 5 minutes.